Good morning and welcome to another episode of Saturday Pharmacist with your host, Hunter Maxwell. And as mentioned 2 weeks ago, our co-host and reoccurring guest, Dr. Franco. How are you doing today, Dr. Franco?
I'm doing well. We're here another week, another thing to talk about, and looking forward to keep getting the word out there about everything that Generation RX does, and maybe getting outside today. Today might be let's get outside. It's getting a little bit warmer every day, right?
Right. The weather's breaking, counting down, as a P3 the last couple exams to my pharmacy career before board. So itching to get outside is something I want to do, but, got to grind for these last couple of weeks. So it's a kind of a continuation from 2 weeks ago. We had the opioid conversation for 2 weeks, which was great. But we fast forward to today's show, and we're going to talk about a life-saving medication called Naloxone or Narcan. So I know you have a lot of experience with this, being heavily involved with Generation RX. So is there anything you wanted to touch on before we dive deep into the topic?
There's a lot out there about naloxone, both from a use standpoint, but unfortunately from a stigma standpoint. So as we talk about everything with naloxone today and knowing us probably more into the future, we'll be sure to talk about it objectively and mention some of the stigma that's out there. And if we can help break the stigma around it, and to those of you who are listening, as always, thank you. But we want to do our best to help educate you as to what the evidence says, so we could break that stigma and get this into the hands of people who need it.
Right. Well said. So, as you mentioned, like the stigma is huge, and today we're going to talk about kind of like the background information of naloxone, how it works for those who are interested, and then how the community and pharmacists and other healthcare professions can get this out to people who do need it and improve the access to the treatment more or less. So, we could start with the basic definition of naloxone and say that it is a medication designed to rapidly reverse opioid overdose in an emergency situation. So it's known as an opioid antagonist, meaning that for those who care, it binds to the opioid receptors in the brain and can reverse and block the effects of other opioids. I believe this was first patented in 1961, so it's been around for quite some time. And it has been approved for specifically a bad reaction of opioids since 1971. So, how does that past use, back in the olden days compared to now, how does it compare to today's use?
Well, I was not around back in the olden days in the 70s, so I don't know. But we'll put it this way: even coming up through school, when I was in school, um, there was not a lot of discussion about naloxone or what naloxone is to the extent that it is now. And it really did take the opioid crisis to bring it into light. Sure, I would be willing to bet that it was used in emergency settings, hospitals and whatnot, if people presented with an opioid related breathing emergency, as you put it, back in the day. Also, back in the day, the drug crises at the time, especially again 70s, wasn't around, but as a child of the 80s, it was cocaine in the 80s, and there's no naloxone for that. And then in the 90s was some designer drugs and early and whatnot, so no naloxone for that. But then when the opioid crisis hit, that's where it really came into light, and its utility since probably 2010 has just skyrocketed because of the waves of the opioid crisis. So been around for a long time, but sort of maturing into its own over the last 10, 11 years.
Okay. So that means, that makes a lot of sense. Obviously, I knew you were not around in the 70s, so I didn't mean to come at you that way.
I know I have gray hair, but come on.
No, I didn't mean it that way, but it's just interesting to see how over the years, how have you seen it grow from the 80s, 90s, and now it's come to the forefront of something that we're kind of seeing every day, especially in our area of Wilkes University, with the opioid crisis being so prevalent. So I guess we could go into how naloxone is used specifically for a breathing emergency. I know we're not showing our face and we're just kind of going vocals here, so kind of hard to show, but for more moral of the show, we can go into it. So it comes as a solution, a liquid that could be sprayed into the nose. So when people pick up their opioid medications, it's usually, I believe it's offered, correct, Dr. Franco?
It's supposed to be offered. Is and should be are two very different phrasings. And we can get into a whole, that'll be a whole nother series as to how we can get more pharmacists to recommend it. But to save time, we'll use it as a teaser for another show down the road.
Great. So as mentioned, it should be offered, and it should be also considered to show your family members or caregivers or the people who you spend time with and know the best to tell if you're experiencing an overdose or a breathing emergency, and how to use this nasal spray and what to do in an emergency situation. So your doctor or pharmacist will show you and your family members how to use this medication, and you or anyone who may need this medication should read the instructions that come with the nasal spray, but it's also best to see if your pharmacist or your healthcare provider could show you, because you're going to get a better feel for it. You're going to see more when you see and you actually physically do it. Is there any technique things that are specific that we should mention, Dr. Franco?
Well, first off, if you're getting this in Pennsylvania at a pharmacy, chances are you're going to get it under what's called the standing order, which we'll certainly speak about. But part of that, you are required as a pharmacist to educate the patient on how to appropriately use it. So there will be education. The real nice thing about naloxone nasal spray is that it's just put in nose and push plunger. It's very similar to using like a nasal spray for allergies. If you have to use that on yourself, it's similar in style, and you just put in nose, push, and off you go. Now, I think the big thing is that once you do give it to somebody, it very well, if this is in fact an opioid induced breathing emergency, they're going to go into withdrawal. So they're going to be uncomfortable. They're going to feel agitated, angry, sweating. They might throw up. So one thing that's suggested is that after you give it to somebody, that you put them into what's called the recovery position. So you just roll them onto their side, and you can Google. It's hard to see it when we're just doing voices, but it's when you roll somebody onto their side, so that if they do throw up, that it's not going to go in their windpipe. That it's just going to kind of fall out of their mouth, to put it kind of bluntly, and as a way to make sure that they're not a harm to themselves or to other people. So that's the only thing that, in addition to how to administer it, that we do request people to do, as well as obviously call 911. That kind of goes without saying.
That's the big one. That's the big one. But I know at the pharmacy that I work at currently, we have the pharmacist show them how to administer the drug, but we also send out a YouTube link on a sheet of paper with the medication, just in case they didn't regurgitate it all back to us to correctly, or, if they have other questions, or if they like to see it for themselves, or just as a refresher. So in my opinion, I think that's a good idea. I think, sometimes people may throw out the link, but, people can keep that link. They have it for the reference. And as you said, it's as simple as Googling if you really want to know and see a better example. So it's there, the help is there. And I think that obviously, like I said, that's one example of good practice. Let's see. The other thing that we should mention is you should keep the nasal spray available at all times in case you do experience a breathing emergency or a bad reaction to one of these medications. But it's also important to be aware of the expiration date. I don't know how often they expire. Do you know? Is it a year like other medications, or?
It has a 2-year shelf life. So we can keep it on the shelf for up to 2 years, but once it gets dispensed, it falls under the purview of any of the other medications that are out there. It can, it would last for up to a year, which is standard for any prescription, or until the date it expires on the packaging. Because if it expires, or there's a recall or whatnot, then all of the protections that the law grants for people who use it kind of go out the window. So you want to make sure that it's always in date when you use it.
Good to note. moving forward, we talked about briefly before how we can improve access to treatment, and you kind of subtly mentioned that we could talk about it in further shows, but just to kind of tease it a little more, we have the improving the access to treatment. So the three, I think I have three here. Yep, three ways that it's been updated laws and regulations to reduce legal barriers to naloxone. So the first one we could talk about was the standing order for naloxone. And I have kind of like the dictionary definition, and then you could kind of give your thoughts about it as well. So I have that the standing order for naloxone is a physician's order that is able to be carried out by other healthcare workers when predetermined conditions have been met, and this can be issued. Under this model, a doctor with a prescriptive authority issues a written order that naloxone can be distributed by designated people, example, a pharmacist, to patients whom the physician has not examined. And this allows broad community access to naloxone.
So that's a fancy way of saying a standing order is a prescription for everybody. It's usually written either state government. So in Pennsylvania, it's been written by the physician general. So as long as that person is in their power, that standing order will hold. And a great example of this was we in Pennsylvania had our physician general who initially wrote this was Rachel Levine, and she got, I guess you could say, promoted to Assistant Secretary of Health at the federal level. And one thing that our state association did with great speed was identify that once she left her post as physician general, that the standing order for naloxone in Pennsylvania would be nullified. So as soon as Pennsylvania's governor appointed a new physician general, it was almost immediate that that person signed the updated standing order, which says the same thing. It's just a different physician's name on it. So there was a continuity that it always changed. Now you just have to put the new physician general's name on it. If you're a Pennsylvania pharmacist who's listening, you have to put the new physician general's name on the prescription when you fill it out under the standing order. You can't put Rachel Levine's name since she's no longer physician general.
Gotcha. So more or less, it's a prescription for everybody, and the doctor does not need to be present in the situation of a breathing emergency when administering this naloxone or Narcan. The second one that I have that's an updated law was the third-party prescriptions, which permit naloxone to be prescribed to people who are not patients of the prescriber. Examples of that would be friends, family, or someone who takes care of a person who is on an opioid. And this ensures that the community members who are closest to someone who experiences a bad reaction have access to naloxone when they need it in a situation. So I feel like this is a kind of adding off of the standing order, just not per that person. Is that correct interpretation?
Kind of, yeah. You obviously, more often than not, are going to have the standing order be how you get it, at least in Pennsylvania. Not every state has a standing order. Every state and the District of Columbia have a means by which pharmacists can dispense naloxone directly to patients without a prescription from a physician or whomever. But no, it's not always a standing order. Some states have protocols through their state board of pharmacy. Some states have actual legislation that were passed, at the state level. So more often than not, it's going to be through direct acquisition from a pharmacy. But this is great because you got to think about it, that most people who are going to end up needing naloxone aren't going to use it on themselves. They're
Right.
more likely than not going to have a family member or a friend do it. So this is where you could go up to a pharmacy and say, I'm worried because my friend, family member, whomever, I think they have an opioid use disorder. I'd like to have naloxone just in case. So I'm dispensing it to this person, billing it to this person's insurance, but the ultimate end user of the drug is somebody else. And honestly, this is just me talking. I think that's one of the things that helped lead FDA to suggesting that it can be over the counter. Now, not no manufacturer has taken them up on that offer yet. There's been some other high pressing issues going on in the world, in case you haven't noticed, for the last 13, 14 months or so. But a recent policy passed by APhA, so the American Pharmacist Association, actually strongly advocates that manufacturers do start moving naloxone over the counter, so that it's not just available in a pharmacy, but you can get it at, you get it at the gas station. You can get it wherever over the counters are sold, so to speak, in a way to help increase access and decrease stigma. Because there is a stigma of going to a pharmacy and asking for it versus casually just grabbing it over the counter, or buying it on Amazon and having it delivered right to your house, like you can with a bottle of ibuprofen. So there's ways that we can get around it, but I know it's a slight tangent, but that's third party dispensing in a nutshell.
So I'm not too, I mean, obviously I'm familiar with it from reading this, but before, the past 13 months with COVID, has there been a push? Was there a push at all for manufacturers to start pushing this towards an OTC, or did it kind of just be like, we already have this prescription, why are we going to make it OTC?
No, there was a push, and obviously FDA has to be the one to green light it to go over the
Right.
counter.
Yeah.
The manufacturers can't just be like, we're going to make this over the counter. They don't have a say in that. That's FDA. So there was the push for it, and it was noted that it could be moved over the counter. But now it just needs that the door's been opened. Somebody just needs to walk through it, and nobody's walking through it right now. So ideally, especially now that that policy was passed at APhA, now we can increase our advocacy for it and increase the push that it does get made over the counter, and it becomes available that way. So I don't want it to seem like we just kind of, we're all, man, we have standing orders or we have mechanisms, so we're good. We know that it was a great step. The standing order was a great step, but there's still barriers, and there's still fear, and there's still trepidation from people wanting to go and get it because they have to talk to a pharmacist. And I think 2020 has increased everybody's social anxiety, as it were, of talking to people. So making it over the counter, or something that you can get delivered to your door, or something that could be part of a curbside pickup, might help ease some of that stigma and make it a little bit easier for patients to get. The counter side, though, is that for patients who aren't financially well off, what are we going to do about coverage and payment? Because currently, under Pennsylvania Medicaid plans, there's no copay for naloxone when you get it under the standing order. But if it goes over the counter, what are we going to do? Is that still going to be covered? I don't know. So for every time we say there's something positive, there's always a catch. So we have to balance it out. And I think that's some of the higher level discussions that need to occur.
Right. And it's something that kind of goes back to my P 1 year. Cost, quality, and access are, three huge important factors for a patient. So what are we going to do about the cost? Hopefully the quality, it's the same as the prescription. And, we also have the access. So we're putting the access out there, which is great. But like you said, what's the negative with the cost? And hopefully there's no negative with the quality. Hopefully it's fine. But in due time.
Yeah, I wouldn't. They're not going to have like, the over the counter stuff is not as good as the prescription stuff. No, it's going to be the same thing. It's going to come down to cost. It's going to come down to the cost to the patient, the cost to the pharmacy to stock it, the cost to the pharmacist or in compensation for it. Is the pharmacy going to set their price? Is it going to be set by the insurer? Those are things that need to be answered. And those are things that are well above, I think, any one particular pharmacist or myself or yourself or our show. But objectively, that's where we're at, and hopefully, we'll see it start to improve.
Great. Yeah, I think that's a great point. And then that third one that I mentioned before, we have the professional immunity and the Good Samaritan laws, which provide immunity to medical professionals who prescribe and dispense naloxone medication, or to medical professionals, or laypersons who administer naloxone. So I don't know. I kind of took this one with a grain of salt and said, this is where we see advocacy and money being thrown into like community groups and things like that. So I found these two statistics. The Health Resources and Service Administration, they awarded almost $20 million, which is, I mean, a lot of money, to support the behavioral health workforce education and training, and also enhancing behavioral health workforce. So it's two little, I guess, groups allocated a lot of money to develop and expand the behavioral health workforce serving populations across the lifespan, including rural and medically underserved areas. So a lot of money to go out to train these people and educate them about naloxone, which is, I think, good. You know, decreasing the stigma, which is something we talked about earlier in the show. I think with all this money and getting these people educated on the topic is going to be huge with the dispensing of naloxone.
And we groups like this, first off, so HRSA, so Health Resources and Services Administration, giving out money is good. And when we look at other federal agencies, so SAMHSA, so that's the Substance Abuse and Mental Health Services Administration, they give out a large amount of money as well to help improve awareness and develop education programs. And one area that they're targeting now is a lot of the rural and underserved areas. And that's because there's no treatment in those areas. There's no primary care physicians in those areas. And there's certainly no psychiatry or counseling or anything along that line. But like we said last week, there are pharmacies in those areas. You could go to the most rural parts of here in Pennsylvania, you could go to the rural parts of the North Dakota or Montana, and there's going to be a pharmacy there. I think I read somewhere before, it's like every town's got like a pharmacy, like a McDonald's, a religious institution. So every town's got at least a handful of set things. So we can utilize that and continuing to find funding for it. And there's been funding from the state level. So that's how a lot of the cities were able to dispense naloxone, just hand it out to people. Back in 2019, there was naloxone giveaways from at least the Wilkes-Barre Department of Health. And I'd be willing to bet, I can't say for sure, but I'd be willing to bet that there was some state money allocated so that they could help, offset the cost of that. And even when naloxone nasal spray first came available, the manufacturer was sending it, because the manufacturer was from Pennsylvania, or was actually sending it to school districts, public school districts throughout the state who wanted it. So there is opportunity to get it out, and I think that's really great and important. And then having that professional immunity in Pennsylvania, we do have a Good Samaritan law in place since 2014 for it, and the requirements are that you have proof of a state-approved training, of which there are two. One of which I believe requires a $10 suggested donation. So do the other one because it's free. And you can Google them. They're on the Department of Health and Department of Drug and Alcohol Programs website. You have to do that. You have to administer naloxone in good faith, call 911, and remain with the patient until help arrives. And from a professional standpoint, unless you're already under investigation for something else by the state, you won't get arrested. You cannot be sued, and the state board of whomever oversees your license, pharmacy, medicine, nursing, whatnot, cannot take any action against your license, which is known as an administrative penalty. So you're immune from all that. And that was all done so that people would do it, because the fear was that if I call 911, I'm going to go to jail because I'm around somebody who's using drugs, or I was using drugs with someone and they happen to have the problem. And they were seeing people get just dumped out of cars in front of ERs, and the car would drive away and they just throw their friend at the door of an ER. So this was meant to help improve that. Now, has it? Well, it certainly has. There's been thousands of lives saved, primarily by first responders, state police in Pennsylvania, since 2015, when the standing order became available. So it certainly works. We just want to keep pushing it more and more and more to people so that they're aware of it.
Right. And touching upon, all this money that's allocated, not only has it been gone to healthcare professionals to educate them, but it's also gone to support groups in the community to help combat the issue of a bad reaction to one of these opioids and help combat the opioid crisis, which we went on multiple tangents in the past two shows. So it's great that the government, state, and federally are allocating the money to these community groups because, as we keep mentioning, decreasing the stigma is huge in this medication. And as you just mentioned previously, a couple minutes ago, about people just dumping their friends off at the emergency room, that's not good for them, and it's not good for that person's health. And we want to take care of everybody that we can who's seeking the treatment appropriately. So if we could, decrease the stigma, increase education of these medications, I think we're going to see a slow and gradual improvement, especially after we combat the current issue going on in the world with COVID-19.
Yeah, when we one thing that I should say that a lot of people will use as an argument is that, well, the state or the federal government is funneling so much money into this. Well, that's all taxpayer money because that's where the state and the government, the federal government, get their money from. So there's a notion that I don't want to use my taxpayer funds to fund this. Like we should be funding roads or improving tunnels and bridges and whatnot. And there was even, I believe it was either in Cincinnati or somewhere in southwestern Ohio, a few years ago, a police sheriff who got on CNN or one of the major media networks and was saying, I'm not giving my people naloxone. I think it's a waste of taxpayer money. This is ridiculous. We're using 5, 6, 10, 20 doses on the same people. And that's no. And first off, that's just horrible to say. That's a human. That's a life. But also, when we look at the amount of money spent on naloxone through taxpayer money, and the amount of money that is otherwise saved in quality adjusted life years, so the amount of people who are saved with naloxone get treatment and go back to work, when all of that is taken into account, it offsets and even surpasses the amount of money that is being spent to get the naloxone in the first place. So we're spending money, but we're actually saving and making more money in taxes on the back end because all those people are going to work and paying taxes because they're still alive. And we can always guarantee one thing: we're alive, we're paying taxes. Like it's gonna happen. We don't like it, but it happens. So that's the argument that we can make against it, is that, and when we look at the work output, the employment output of people who have been saved by naloxone, that it supersedes the amount of money that is being spent on it.
Right. And I think that's a great point. We're always going to be paying taxes. So saving lives is also obviously very, very important. So I think that's a great point that you brought up with that cop and that example. And finally, kind of just summarizing the show, obviously we can talk about naloxone in the future episodes, but this is kind of just like a teaser and just the basic things about naloxone that we could talk about. So other ways that we can prevent a bad reaction or help with substance use disorder that I found through some resources online, not just with naloxone, but we can increase the availability of opioid dependence treatments, whether that's in treatment centers or with other medications, and we can include those for those dependent on opioid prescriptions. And then we could reduce irrational and inappropriate opioid prescribing, which we talked about, like I said, the past, well, I guess you could say 4 weeks, but the past two shows would be more appropriate. And then we have monitoring opioid prescribing and dispensing, and then we can limit inappropriate over-the-counter sales of opioids. So those are just some quick, easy ways that we can educate and advocate for safer, healthier patients.
And we look at this, and as you said, I think the big one here is focusing on treatment, because we can limit opioid prescribing, and we can limit over-the-counter sales of at least opioid. You're not going to get like over-the-counter oxycodone, but you can get over the loperamide, which is Imodium, and Imodium targets opioid receptors. They just happen to be on the gut to prevent diarrhea. But if you take enough of it, it could have an effect. So we can look at that, but if we limit there, people are just going, it's going to be repeating 2010. We limit there, and people are going to go to the path of least resistance, which is going to be the street and heroin and fentanyl and whatnot, which is exactly what happened in 2010. So I'm not saying just pedal to the metal opioids in practice. No, I'm saying that we need to be more cautious in what we do. Opioids are appropriate for certain people and certain conditions, and we shouldn't deny them that. You're thinking certain chronic pain conditions, cancer, and so on. But it's really getting access to treatment, because we can curtail what we're doing with opioid prescribing, but we don't have any control over what's happening on the corner of Broad and Main Street. I have no control over that. So how can we get around that? And that's going to be increasing treatment access, treatment availability, and decreasing stigma that is associated with treatment. And we brought it up before that it seems bad enough that substance use disorder itself is stigmatized, but the treatment is even more stigmatized to a point in certain parts of the country.
Right. I think that's a great ending point for the summary of the show. The last fact that I want to mention is actually the gap between recommendations and practice, kind of contradictory. So it says only half of countries who provide access to effective treatment for options for opioid dependence, less than 10% of people worldwide in need of such treatment are receiving it. So it just goes to show you the stigma behind the treatment that you just mentioned.
Yeah, even that's worldwide. That's just, again, imagine if worldwide 10% of the world's population, only 10% had access to the COVID vaccine, and that nobody else could get it. Only 10%. That would be there'd be pandemonium. When we look at it in terms of the U.S., it breaks down to about 30 million people who need access to care, access to substance use disorder treatment. 30 million people don't have any access, which is a fairly large group of people to not have access to care. So things we can continue to advocate for, I guess, right?
Yep, advocacy is huge, as we mentioned pretty much every show so far. So continuing the advocacy, not just in pharmacy, but in other healthcare professions who work among us and with us. And I think that was enough of the conversation for naloxone. I want to thank you again for your time, as always, Dr. Franco. I know we're pushing close, almost time for class. We're recording this during the week, so be tuning into a great class with Dr. Franco shortly in probably about 5-10 minutes. So just to wrap up, we greatly appreciate everyone who listens and shares our podcast. So please subscribe and smash that like button and subscribe to our page on YouTube, the Wilkes American Pharmacists Association page, and follow the Saturday Pharmacist playlist under this show here. If you have any comments or concerns, the comment section is always open. And thank you to our listeners and current subscribers for tuning in. We are on Spotify now, so check the link in the description. And we will post another show in 2 weeks. So on behalf of Dr. Franco and the Generation RX Student Driven Podcast, my name is Hunter Maxwell, and keep it real and stay safe. See you guys shortly.